Welcome, friends. It is our great pleasure to introduce you to SICOT-PIONEER.
Postoperative muscle strengthening and exercise. The diagnosis in most of the time is relatively simple. Intraoperative injuries are obvious. Partial tendon injury should be identified and repaired immediately. And postoperatively, the knee need to be immobilized for it to heal. History and examination are mandatory. X-ray is also important to rule out fracture of the patella. In partial chronic injuries, it might be useful to do an ultrasound and rarely MRI, which I have never used for making a diagnosis of extensor tendon injury. Management treatment is generally surgical repair versus reconstruction, depending on the available patellar bone stroke and chronicity of the injury. So quadricep tendon rupture, partial injury could be immobilized for 6 to 8 weeks. Acute injury with complete rupture would require operative intervention, transosseous fixation, anchors on the patella, and direct suturing have a re-rupture rate of more than 40%. Chronic reconstruction, autograft with using semitendinosis and gracilis, allograft using Achilles tendon allograft, or complete quadricep allograft with patella and patellar tendon quadricep, and then synthetic Dacron or Marlex. This is how a quadricep tendon rupture near the patella has been repaired with tracheal suture, and this could be further reinforced by biological and synthetic thing. So patellar tendon rupture incidence is 1%. Etiology is same. It is always surgical. Acute partial require direct suturing, complete transosseous fixation, and chronic will require allograft. So you can see here that the gracilis and semi-T tendon have been harvested and they've been put over the patella for reconstruction. I'm just going to show a few cases. This is an X-ray of a 69 years old female patient, had total knee replacement 2 years ago, had accidental fall. In the lateral view, you can see that the inferior pole of the patella is fractured. So these are intraoperative pictures where anchor sutures have been applied, primary reconstruction. On the extreme right, you can see the hamstring tendon overlooping, and this has been further reinforced with a claw plate. And these are post-operative pictures. Patient was allowed full weight bearing, but no bending was allowed for 6 weeks. Another patient where hamstring graft have been taken, and this is further reinforced with mesh. These are post-operative X-rays, and you can see anchor suture. Another patient, you can see, this is the clinical picture. Above the patella, you can see a gap. These are intraoperative pictures. So primary repair in this case was done about 18 years ago, primary repair. And at that time, I had Prolene mesh. So this had been repaired. Another patient.
Zone 1 is a surface fixation. So while doing a revision total knee arthroplasty, one should aim at least 2 zones of fixation on either side, on the femoral as well as on the tibial side, which will provide a good component fixation for a good long-term outcome. Now, why should we use a stem? Because the use of stem will protect the juxta-articular bone, which is lost during the revision arthroplasty because of osteolysis or fracture or whatever. And it also transfers the load from the compromised metaphysis to a stronger diaphyseal regions. Now, there should be a balance between overshielding and overloading of the juxta-articular bone, because overshielding may happen if you use a too long a stem, which can lead to stress shielding and give rise to pain at the tip of the stem. And if you're using a stem which is too loose, then it may overload the juxtaarticular bone. So one should, aim at achieving a balance between the overshielding and overloading of the juxtaarticular bone, and that will vary from patient to patient. Now, when to use a stem? When the remaining bone stock is insufficient, like you see in this case, whenever there is a segmental deficiency of the tibia, as in this case, here it requires some blood transmission. Whenever you're using bone grafts, to offload the grafts, you require a stem extender. And sometimes when you use the, augments, metal augments or sleeves or cones, something like that, then in addition to metaphyseal fixation, your stem extender will provide a diaphyseal fixation. In periprosthetic fractures like Rodabeck type 3, when there is a metaphyseal bone stock is deficient with a loose bone stock, you need a stem extender in order to fix the components. And in case of periprosthetic fractures type B, Felix in on the tibial side, also you need a stem extender. Now, the extent of offset adjustment requires a stem extender so that there is optimal position of the components both on the femur as well as tibial side, as seen in this patient. Now, which length and diameter? The aim is to reduce the micromotion as far as possible, and that is reduces by increasing the stem length, the diameter, and of course the canal filling ratio, which is defined as the ratio between the diameter of the stem and diameter of the intramedullary canal. And one should aim at achieving more than at least 85% of the canal filling ratio. There is no ideal length in the literature described, but the surgeon should aim at, depending upon the patient's anatomy, the bone loss, and type of constraint which is required for that particular, type of revision surgery. And at least one should aim at 4 centimeter of diaphyseal engagement while putting a long diaphyseal, hybrid type of fixation. So, but the stems, they lead to, they force the articular component into a suboptimal position. One should look at that. And you require a greater press fit, even in case of when there is severe bone defects or whenever there is a severe soft tissue insufficiency. But one should see that, in case of narrow canal, it is difficult to use long stems, and their short stems have been often useful in these kind of cases, and hence long stems are preferable. Now, the fixation method, the hybrid type of fixation is usually preferable because that preserves the bone structure and it is easier to remove the stem during the second stage of surgery while doing a revision surgery, and especially whenever there is a previous deformities like high tibial osteotomy or distal femoral osteotomy, then a hybrid fixation helpful using a long stem. But remember in the long stem that there's a possibility of end up stem pin because of the stress shielding, and that may lead to suboptimal position of the components as well. And moreover, there is a possibility of periprosthetic fracture at the tip of the stem due to stress shielding. This is one of the patients, a 73 years old female, where long stem has been put, and that led to suboptimal position of the tibial component, which is more posterior and more medial placement of the tibial component. And as you can see here, that over the period of time, how it is causing a stress shielding there, and there's a possibility of fracture there. Whereas the cemented stems are preferable in some cases because it's easy to implant. It's a good metaphyseal bone stock, and it provides better initial stability because of the cementing technique, and it elutes the antibiotic in the around tissues and around the bone because the antibiotics can be added to the cement, and the component position and sizing can be adjusted in a cemented type of stem. And especially in cases where the osteoporotic bone, or if there are diaphyseal bowing, then it's preferable to use a cemented stem so that it doesn't affect the intramedullary canal or alignment of the bone. But having said that, it is difficult to remove when you do a re-revision surgery because the entire cement also needs to be removed, leading to greater bone loss during the re-revision surgery. Now, sometimes we prefer to use a long cemented stems as well as in certain systems. This is a link system link hinge type of knee, where after taking out the components, there is severe bone defects, and long cemented stems are helpful in certain cases because it prevents stress yielding and prevents tip of the stem pain as well. Now, offset stems are a beautiful, bone in the armamentarium because it optimizes the component position, especially in the sagittal plane on the femoral side. As you can see here, it's in a neutral stem and it's an offset stem. How we can, decide about the component positioning. You can decide, you can shift the components little posteriorly or anteriorly, adjusting the offset. And here in this case, on both sides, using the offset stem, how the component positioning has been pretty anatomical, both on the tibial side and the femoral side, in the sagittal as well as in the coronal plane, simultaneously maintaining the alignment of the components. So what is my preferred technique? I expose till a good inner cortex. I use a press fit, usually hybrid type of fixation. I rib approximately 1 centimeter past the tip of the stem, which prevents an impingement and the pain, of course, keeping in view of the cortical thinning. I rib until I get a good fit, so that which will be sufficient to lift the leg. This is the last trimmer which I use, so that with that I can lift the leg. That is the optimum stem diameter for me. And I prefer a hybrid fixation unless there is a femoral bowing or severe osteoporosis which is present. So friends, take home message. Use of stems during the revision knee replacement, it protects the juxtaarticular bone and helps in the load transfer from the metaphyseal bone to the tough diaphyseal bone. Remaining bone strength, when it is insufficient, especially it provides a good zone 3 fixation or diaphyseal fixation. The length of the stem and the diameter of the stem depends on the specific to the patient's anatomy, the amount of bone loss, and what is the amount of constraint which is required. One should aim at the canal filling ratio, as I told you, more than 85%. Cemented stem is preferred when you use a small length stem, whenever there is a narrow canal, and of course there is a deformity in the metaphyseal-diaphyseal region. The hybrid stem is preferable and it can be used, longer stem can be used, the ease of removal and longer stems can be used, and it can restore the mechanical alignment of the limb during the revision surgery. And offset stem is a beautiful bone in the armamentarium because you can optimize your component positioning using the offset stems. I thank you for a patient hearing.
Thank you, Shubhranshu. Great talk on stems. Great pleasure to welcome my very dear friend, Vaibhav, who's going to talk to us about constraint and revision. And I believe he's just coming out of surgery where he's used all of his skill sets with constraints and stems and augmentation. So, Vaibhav, all yours.
Thank you, sir. It's always a pleasure to interact with you and learn from all of the experts here. Thank you, Mojieb bhai. So I'll begin with sharing my screen. Just 1 second. Is this screen visible now?
Yes.
Okay. So thank you once again. So I'll begin with the case. This is not today's case. It's day before yesterday that I did. She's a 65-year-old female, 2 years since index surgery. A rotating platform was used, done bilateral simultaneously elsewhere. Never felt all right on the left side, no pain, fever, feels giving away sensation. These are the x-rays, varus valgus views, and the alignment view. So I'll leave it at there. We will come to this case at the end, and I would just want you all to start thinking on what could be done and what is the most appropriate strategy in this case. So when I look at how do we choose a constraint, I think it's always a balance, and we balance the stability with the function and the longevity. So the dictum is to use least amount as possible, but maximum amount as required, because it should be sufficient enough to give you stability. At the same time, if you use a more constraint, it will impair the function and also possibly the longevity. So let's look at what happens when biomechanically when we use a constraint design. So constraint usually means a substitute for the soft tissue, which is deficient or not functional. it increases the capability to transmit the load to the fixation of the bone. And because of this, the stress across the bone implant increases, affecting the longevity of the implant. When we look at the choices that we have, we could do a cruciate retaining, we can do a posterior stabilized, we can use what's called as a varus valgus restraint, or we can use a hinged knee replacement. So this is all the spectrum of what choices are available to us. And we'll go systematically looking into when we use a particular type of constraint. So we start with the decision making, and the decision is based on two things. It is primarily the soft tissue status, but also you may have to take into account the bony defect that the patient has. As I said, we'll begin with the least constraint, which is the cruciate retaining. So when or where do you need to do a cruciate retaining? You need a perfect flexion extension gap. You need to preserve the joint line. You should almost always have an intact and functional PCL. And the advantage is it preserves the bone when you're doing it because you're not taking any notch cut. And also the functioning PCL with its proprioception is an advantage of getting a knee that feels nearly normal. In contrast, the PS implant, which is the posterior stabilized implant, offers stability against the posterior subluxation of the tibia in the flexion of the knee. It, however, does not offer any protection against the mediolateral instability. And if the gaps are not balanced, meaning that the flexion and extension gap, there is a mismatch, then there can be a tendency of dislocation of the post and cam mechanism. And just putting a thicker insert would not solve the problem because it would still cause an imbalance of the extension gap. On the other hand, if we raise the joint line, that's also not good for the patellar tracking. So when you're using PS implant, we should be mindful that they are not a substitute for a poor balanced knee. Coming to the next in continuum is what we call as varus valgus constraint or an unlinked constraint because the components are not linked to each other. They are used in the situation of deficient collateral ligament. They offer an intrinsic varus valgus stability. So whenever there is an instability or the flexion gap laxity is large enough that cannot be addressed by a PS implant, then we use a varus valgus constraint. And what's the design that's there? They have a deeper and larger intercondylar box. And so correspondingly taller and broader post is required so that it can accommodate that cam post mechanism. But one must remember that it does not protect against hyperextension force because they do not have any impact on the posterior soft tissue tension. If you look at the image, this is how it looks like. So this is how it looks like. So you'll see this is the PS implant and this is the varus valgus constraint implant. And you'll see a taller box there. So it removes more bone, but it also gives the stability to the joint. But Barak et al. Gave certain criteria. When will VVC suffice? It only will suffice when your flexion extension gap difference is less than 10 millimeter, that you have been able to restore the joint line within 10 millimeter of the physiological status. The femur is reconstructible in the AP dimension, and at least some functional fibers of the collaterals are intact. So we should use VVC only when all of these conditions are met. If they are not met, then of course we should think about a hinged knee implant. A technical tip, preferably one should use stems with the use of these implants and have a low threshold for using the sleeves and cone. Because if you look at it, although they are lower in terms of constraint, they are even more constrained than a hinge because there's no rotating mechanism here. And so the forces that are transmitted to bone are very high. And that's the reason I say that we should use sleeves and cone much more commonly. Now, hinged knee prostheses have been historically used since 1950s, but the results were poor because of the high constraint. The use is limited today for tumors, extension deficiency, and the neurological conditions. Rotating hinged knee prosthesis was developed to overcome the flaws of the hinged knee prosthesis. And by permitting rotational freedom, it helped redistribute the forces passing through the bone implant interface. It also ensured that your patellar tracking and the patellar stability was good. So it's a really good tool in the armamentarium when you have lot of or global instability. It has to be used when you cannot balance with the implant placement, PS or VVC, where there is severe bone loss and specifically when the bony attachment of the ligament is compromised. Of course, it can be used in the situation when there are tumors and periprosthetic fractures with loose implant. So these are the indication for the RHK use. Now, while we say that most of the time it's the soft tissue that determines the use of constraint, but there is a school of thought that says that even with bone defect, there is a rationale in using the constraint because they are always go hand in hand. So this is our case that we did where we saw when I put that thing up, this is how it is opening up mainly the posterolateral instability and hyperextension. So you'll see that how when we do that, the poly is spinning off and this being rotating platform, there are choices. We can do a full revision. We can convert only the tibial side into a PS implant. Think about even hinge some people. So what we did was we combined both the implant and soft tissue. So we used a thicker poly insert and did a PLC reconstruction. So I think this is also one of the techniques when you can look at the hybrid technique of addressing both the biomechanics as well as the soft tissue component. This is the post-op X-ray of the same patient. And in conclusion, we should use the least constraint possible, build the bone defect with the graft, wedges, sleeves, or cones, assess the balance of flexion extension gap before determining the choice of constraint. When the osseous attachment of the ligament is compromised, an RHK implant is preferred. Of course, when there's a hyperextension too, an RHK is preferred. When there is a comminuted periprosthetic fracture with possible loose implant, a hinge needs to be done. And when you have increasing constraint, have a low threshold for using stems, sleeves, cones. There's a complex algorithm of managing instability with each of these components. So look at extension instability, recurvatum flexion, the mid flexion instability, and there is a way in which you can think about soft tissue and the osseous attachment going with it. So in the end, I will only say that one should use the minimal constraint and achieve the maximum balance. So this is the video of our patient. You will see after the reconstruction, you will see we are tensioning the PLC there. And with that, there is no subluxation now with just a thicker poly and PLC reconstruction. I thank you for your attention.
Thank you very much, Vaibhav. Our next speaker is Dr. Fouad Sadek from Cairo University, who's the head of pelvis and hip arthroplasty unit. He's a professor of orthopedic surgery, and he'll be talking to us about restoration of joint line and revision total knee arthroplasty. Over to you, Dr. Sadek.
Thank you, Mojieb. Thank you, everybody. I'm going to start by sharing my screen. So is my screen visible now? Okay.
That's
Hello?
fine. Go ahead, Fouad. Yeah, we can see it. Go ahead, Fouad.
Okay, thank you very much. Okay. Well, I'd like to thank the previous speaker who made my talk a little bit easier. And I cannot overemphasize the importance of restoration of the joint line. For some reason, this doesn't want to proceed. It doesn't want to go for some reason.
You can press the left lower corner.
I'm trying to do that. Oh, yes, now it's working. Okay. So we know the objective of a prosthetic replacement by having patient satisfaction with a well-aligned implant producing the full range of motion, which is stable. And we also know that in a primary total knee arthroplasty, joint line because of preservation of the anatomy. But in a revision case scenario, the equation becomes more complex and balancing the gaps and the soft tissues can come on the expense of the joint lines. So we know that the joint line gets disturbed with bone loss because it allows the femoral components or the tibial component to be put in a misposition. Combining that with scars and flexion contractures, and the condition becomes more difficult. The literature have definitely showed us that we need for the best functional scores to keep the joint line within limited ranges, less than 8 millimeter elevation from the tibia. And we also know that in the revision case scenario, not infrequently, we end up with malposition of the joint lines. And this is why there has been strong recommendations of trying to preserve the femoral joint line to have the best postoperative range of motion. We also know that an elevated joint, in addition to disturbing the quadriceps mechanism and overstuffing the patellofemoral joint, will produce mid-flexion instability, a situation which arises because the tight posterior capsuline extension will protect the extension gap, giving an erroneous feeling of stability of the collaterals. And in full flexion, the quadriceps mechanism stabilizes it. And once we go between the full flexion extension, then we go into mid-flexion instability. And we also know that the low-riding patella not only decreases the lever arm of the extensor mechanisms, producing impingement and anterior knee pain, but also increases the polyethylene wear, as well as the depression of the joint line, which tends to increase various degrees of stiffness on the knee and overstuffing the patellofemoral joints. Many bony landmarks have been suggested as reference points for the joint line position, namely the femoral condyles, the fibular head, and patellar tendon, and giving simple landmarks from the head of the fibula, the tibial tubercle, and the lower pole of the patella has been found to be not very reliable. And MRI-based researches have suggested that we might as well use ratios in relation to the distal femoral width and the proximal tibial AP diameter, recommending a tibial tubercle instead of the fibular head and the lateral epicondyle instead of the medial. So before we go on to the various step-by-step maintenance of the joint line, we have to assess the patellar height to make sure that we do not have an excessive patella baja and excessive short patellar tendon. And also, we have to look at the ligament status, and we have to stress the fact, what was actually iterated by the previous speaker, that not always a constrained joint is the key. So we like to suggest these 6 step-by-step procedure for maintaining the joint line. We start by the tibial reconstruction first. We proceed to the flexion gap, followed by the extension gap. And why the tibia first? Because anything you do on the proximal tibia will affect both flexion and extension gaps equally. And so we aim at aligning the tibial tray at right angle to the mechanical axis so that the tibial tray will act as a plafond, as a landing site for the knee. Then we proceed with the flexion gap, knowing that we can manipulate the size of the femoral component and the translation and rotation of the femur. And the extension gap have to be equalized to that by choosing the ideal distal position of the femoral component. Needless to say that once we change the position of the femoral component, this has to be associated with a buildup of the defect both distally and the posterior offsets. The two sides of the same coin are restoration of the joint line and gap balancing, and both of them have to go hand in hand. And the same principles that we use to have a squared extension and flexion gap, which have to be equal, are applied also in the revision case scenario, remembering the different few tips of the balancing technique. And the one thing I'd like to stress upon is that when you have a tight extension gap, we should start by resorting to the releases rather than resection, because resection tends to change the joint line. So we can have 9 sort of permutation between either a loose, normal, or a tight flexion gap with a loose, normal, or a tight extension gap. When both gaps are normal, this is the ideal situation because then the goal of revision is met with a balanced collateral ligament. But when we start with a tight flexion gap, the 3 options with tight, normal, and loose extension gap work as follows. Obviously, 2 tight gaps are easily treated by resection further of the proximal tibia, but within a certain range, because if we extend that too much, we can actually produce joint line depression. When the extension gap is normal with a tight flexion gap, then reconstruction can be either by resecting again the tibia with distalization of the femoral component and building up the femur distally, something that increases the risk for joint line depression, or downsizing the femoral component. We have to remember that anterior translation of the femoral component will put the patellofemoral joint at stuffing. If we have a loose extension gap with a tight flexion gap, we can still do the same by resecting again the tibia, which increases the risk for a joint line depression. And if we downsize the femoral component, we need to augment the femur distally. And again, we should avoid anterior translation of the femoral component. What about a normal flexion gap? A normal flexion gap with either a loose or a tight extension gap work as follows. The loose flexion gap with the loose extension gap with a normal flexion gap is not a problem because simply reconstructing the distal femur will solve the problem without jeopardizing the joint line. Whereas a normal flexion gap with a tight extension gap is a problem, because this is when we start to resort to resection of the distal femur. For that, to avoid elevation of the joint line, we suggest working on the posterior capsular release, trying to minimize the difference between the tight extension and normal flexion gap. What about a loose flexion gap? The loose flexion gap is the commonest situation, the commonest scenario in a revision scenario, and this was mentioned before. And we can either have a tight normal or a loose extension gap. When we have a loose flexion, tight extension, this is the most difficult situation because distal femoral resection becomes significant, and that definitely will increase the joint line elevation. Extensive posterior capsular release can minimize the difference, but sometimes it fails to do so. This is where we resort to certain tricks about how to fill a large flexion gap. And in these cases, we change the size of the femoral component by upsizing, and we use what was mentioned before by using offset stems to posteriorly translate the femoral components. So in this case, a normal extension gap with a loose flexion gap is easily reconstructed without disturbing the joint line by changing either the femoral size or translating the femoral component posteriorly. The most difficult class situation is a loose flexion, loose extension gap. And obviously, intuitively, the simplest way would be to use a thick poly, but this is definitely something that will lead to a joint line elevation. So extensive playing here is needed by changing the size of the femoral component, doing all kinds of tricks to change the position of the femoral component as well to obtain a stable situation with equal gaps. And sometimes in this situation, we might need to resort to more constrained implants. So lastly, before we finish all the steps, we need to check that we do not have a midsection instability and that the patellar height is ideal. So my take-home message is that joint lines are extremely important. When you have intact collateral ligaments, jumping to constrained implant is not the right choice. We need to go step by step for gap balancing, avoid midflexion instability. When you have tight gaps, first start the releases, then the resections, and try to avoid high level of constraint for your implants. Thank you very much.
Thank you, Fouad. Excellent talk on a very, very interesting subject in revision total knee arthroplasty. I'd like to now invite my good friend Mojieb, my co-moderator, and he's going to talk to us on the unstable total knee replacement.
Thank you very much, Ashok, and welcome everybody. It's my pleasure to be talking about unstable total knee replacement. This will be my point of presentation. And this clinical entity is defined as an abnormal and excessive displacement of articular elements of a total knee that eventually leads to clinical failure of arthroplasty. It may be the cause of revision in about 10 to 22% of cases. Constraint and balance are not the same thing, as very elegantly explained by Dr. Bagaria and Dr. Fouad Sadek. Well, balance is defined as a dynamic process which relies on ligament function and appropriate tension that is determined by appropriate restoration of joint line and bony articular surface, and also well balancing of coronal and sagittal plane of the total knee arthroplasty. The constraint, on the other hand, is a mechanical substitution of a defunctioning ligament that can solve the acute instability issue by certain design of implant or bearing surface. However, this carries a long-term risk of fixation. So what we aim in a properly balanced total knee arthroplasty is well-balanced knee with use of minimal constraint. Clinical presentation could be variable, could be an abnormal sense of giving away by patient. The patient feels that there's no confidence in his or her joint, particularly when they go down the stairs, or they're getting up from a sitting position. They may have a buckling sensation and quads weakness. This is not a diagnosis. Instability is a diagnosis, but not a cause. So with the diagnosis of instability, we got to find the real cause and etiology. We need to understand the kinematics of the knee, which is determined by femur. The posterior part of the femur determines the flexion of space, and the distal part of femur determines extension of space. And depending on where the instability is, we need to focus on working on filling that gap, either flexion or extension. And remember, it's not always a faulty ligament. It could be because of mismatch of flexion extension spaces, could be due to fracture existing down there, or a component which is malpositioned, loose, or a broken component. There could be bone defects. And lastly, there could be ligament failure. In order to fix any unstable total knee replacement, we need to have a very proper and organized technique that starts by properly balancing the flexion extension gaps, choosing the right component, appropriately sized, put in appropriate position and rotation, and final restoration of the entire alignment of that particular knee. Although it could be classified in the direction of the instability, I prefer an etiologic classification. Type 1 is a bone deficiency, type 2 ligament and soft tissue deficiency, and type 3 would be a combination of both. So bone deficiency will be either that the component were positioned in a malposition situation, or they were properly positioned, but then they became loose, subsided, and there was a secondary malposition. Ligament and soft tissue deficiency could be iatrogenic at the time of surgery, or it could be because of pre-existing congenital neuromuscular disease. We've seen this algorithm by Dr. Fouad, and the commonest scenario will be a loose flexion with either normal or tight extension, commonly caused because of the femoral component has been either undersized or anteriorized with an insufficient restoration of posterior condylar offset. And CR knees, it could be because there has been a rupture or failure of the PCL or a failure of the CAM and post mechanism in a PS knees. Sometimes you ought to use a thinner poly to allow restoration of full extension, but that is not thick enough to restore your flexion. And this is the clinical picture of flexion stability with the knee put in 90 degrees. And you can see the entire leg sagging posteriorly. And with a loose flexion space, the entire knee can jump forward with the femoral component jumping over the post in a PS type of knee. This is a typical picture of a patient who had restoration of the extension space with thin poly, as well as the usage of a very undersized femoral component that had to be upsized 2 sizes. And I used a posterior offset stem to fill in the posterior flexion gap. And as you can see, I did not have to use any type of constraint insert. The problem was actually in the soft tissue balance and filling up the flexion space. This lady had a CR knee. About a year later, she had instability due to rupture of the PCL, went to different physicians, different hospitals, multiple type of examination investigations, and her diagnosis lied in a simple listening of what she will tell you, that she has a problem getting up and going down the stairs. And if you examine her physically, she was having posterior sagging and end up with having a proper revision. On the extension side, you may have either a hyperextension stability because of pre-existing neurologic disease or because of weak quadriceps muscle. Intraoperatively, if you do an overzealous posterior release or an aggressive distal femoral cut, it will result in a hyperextension instability and also elevation of the joint end with the result of mid-flexion stability, as was showed by Dr. Fouad Sadek. Patella bar in our part of the world was shown to be about twice what's in the literature and 10 times what's in the US. So that's something to keep in your mind by avoiding any distal femoral resection if you can get away with doing a posterior release. These are the commonest cases of coronal instability where medial release is not properly done and the patient has a persistent adductor thrust due to persistent contracture of the medial collateral ligament and collateral lateral laxity. And this is a typical example where we not only had to resort to medial release, but also had to build up that medial space to restore appropriate tension. This patient came with a persistent adductor thrust. You can see that the varus was not corrected. Medial release was not performed on top of an internally rotated femoral component. This example of a second stage revision total in sickle cell disease, where we're able to obtain a properly functioning stable knee without having to use a constraint insert. This was a mid-level constraint, and all we had to do is restore the bone defect and appropriate balancing and flexion extension space. Similar case here, this is an IB2 type of total knee that was done 22 years earlier, and it failed due to loosening and collapse of tibial component in varus, and we were able to restore the component with using a CCK type of insert without having to use the hinge. Once we restored the alignment properly and fill in the bone defect. Keep in your mind that the extreme of a coronal instability is when you have a defunctioning MCL, and in doing so, a CCK type of insert is not a substitute. You have to use a hinge, and ligamentous failure is not the same as bone loss. And if you see this example, this is a faulty technique where an RHK type of insert and a femoral tibial component should have been used. In patellofemoral case, if you do not have a proper restoration of femoral component rotation, that will lead to patellofemoral instability. Sometimes you also have to look into the femoral tibial rotation relation, because an excessive externally rotated tibial component might give you a relatively internally rotated femur with a maltracking patella. This is an example of how the pins were improperly placed on the left side. This would have resulted into an internally rotated femoral component because they were not parallel to the transepicondylar axis. This lady had 2 episodes of polylinear exchange because nobody bothered getting a skyline view, which clearly shows an anterior rotator femoral component. So in conclusion, you got to identify the potential cause of instability. Remember that the femur is the one that controls the kinematics. Have a very stepwise surgical techniques, starting from the establishing of the joint line, both in flexion and extension, balance the flexion extension gaps, as well as appropriate rotation of both the femoral and the tibial component. If there's any malalignment, correct it, neutralize any deforming forces, and try to use as little as minimal constraint as possible, starting from PS, and then go ahead, keep on going up. Remember, maximum balance and a minimal constraint, and if you don't plan well, you're going to fail. And no matter how well the technology is in our disposal, that would not substitute for a proper clinical wisdom in clinical assessment of history, physical, and solid surgical technique. Thank you very much for your attention. It's my pleasure to introduce my next speaker, Dr. MajidAlYamani, who is a consultant orthopedic surgeon with a specialty interest in joint replacement, oncology, and sports medicine. And he's my colleague working at Johns Hopkins Aramco Health Center in Tehran.
Mojieb, can I interrupt just for a second? I have an emergency in the hospital, so I need to get back. I apologize, but it's the last talk, and I'd like to thank all the speakers and Sufyan, and I would need to exit the symposium at this time. Thank you very much.
No problem, Ashok. Go ahead.
Yeah.
Go ahead, Dr. Yamani.
Okay. Trying just to share with you my screen. Am I on?
Yeah, you're on. We can hear you, but we can't see you. Yeah, okay. We can see your slide. Yeah. Yeah.
Okay, good. So thank you very much for inviting me for this. I really enjoyed it and learned a lot from all of the previous talks. I hope no one of us comes into this situation where he lost all of his resources and came down to a megaprosthesis. So megaprosthesis, as the title in here, is when everything fails. I will start with an example of a 65-year-old lady who presented with pain, typical arthritis. She underwent total knee replacement, and this is what happened intraoperatively. And what could go wrong, we all know, and this is actually what happened to her a few days after the surgery, just with ambulating the lady. Then, what to do? This is now a big story that you can actually go with a periprosthetic fixation, and we can kill that topic discussing it with an intramedullary nail or a fixation with a plate and screws, and all of the options are there. But this is what the surgeon picked at that time, and this is not during our time in Jaha, Dr. Manzary. So the patient came after a few weeks with this kind of X-rays and with this kind of failure of the fixation and of the implant itself with loose component. So this is where you think that we cannot actually go back and try to balance any kind of constrained knees or prosthesis that could help this patient go back to ambulatory level. So what to do? The indications for megaprosthesis is the elderly patient with loose implant and insufficient bone stock, patients who require short hospitalization, either due to comorbidities or activity levels, and periprosthetic extensive fracture or non-union with significant bone loss. The disadvantages of those kind of megaprosthesis are the cost, which is huge, and the lack of further revision, because the next step may become just the amputation or accepting a fusion, or which is actually not acceptable in those days, and the increased risk of hardware failure and dislocation. Increased risk of infection is very significant compared to a revision total knee or a primary total knee. The challenges are very clear, and they're more or less the same as before, which was illustrated by the speakers. But we mainly concerned about the extensor mechanism, particularly leaving the lateral column of the tibia. Secondly is the tissue adhesions. Usually those patients come to you after several kind of surgeries. So you have to respect the tissue and you have to identify the layers and try to be more conservative with sacrificing muscles because they don't have a lot of muscle bulk at that time. Osteoporosis is a given for elderly patients, and also skin problems, especially if you come to replace the proximal tibia for patients with failed total knee replacement or failed revisions. So as we said, we have to preserve the patellar tendon. We have to preserve the tibial tuberosity as much as we can, though we have a lot of cases where we should fix that patellar tuberosity to the proximal tibia replacement. And those are the toughest case where you have to treat your patient, trying to avoid any kind of infection that could happen in the near future because the infection rate is very high on these patients. Silver-coated implants, actually, we're using them nowadays. And you have to consider any kind of measures that could reduce infection because infection is very high on those patients. In the outcome is much more better if you are addressing only the distal femur. So the Oxford knee score is 27.5 and the KSS is 77. When you compare it to the proximal tibia, there is a huge difference, of course, on the functional outcome. And the proximal tibia also has the highest rate of infection that could reach to 16%. So back to our case, what we did was the distal femur replacement, of course, after checking the vascularity of the lower limb because of the dislocation. And the patient did well after that. So the take-home message is the megaprosthesis is a valid option, but please leave it to the end. Periprosthetic fractures, loose implant, and insufficient bone stocks are all of the most indications or most cases where we use to do the megaprosthesis. The best outcome with the distal femur, as we said, and preserving the mechanism is very important, the extensor mechanism, soft tissue coverage, and surface modification. Thank you very much.
Thank you very much, Dr. Yamani. Great talk. And by this, we are at the end of our all the talks, and I do welcome any question from the audience or from the speakers. Would like to facilitate some discussion, and thank you very much, guys. All talks were amazing, absolutely fantastic talks from the first speaker till the last one. Sufyan, do we have any questions from the audience?
No question so far.
So, one question to Dr. Sadek and maybe to Vaibhav as well is that if you have a tight extension and a loose flexion, tight, not a normal extension, a tight flexion, and a tight extension and loose flexion, how much can you go up on elevating the joint surface if the patient did not have a patella baja and the earlier or index surgery had already had, regular distal femoral cut? So it was not like it was a shallow cut or a decreased cut on the distal femur initially.
Okay. Thank you very much, Mojieb. I think this is a very good question indeed. Obviously, lucky to us, this is not a very common scenario because if you really have such a loose flexion gap, it's unlikely that you really have a very tight extension gap. But then, obviously, you can meet it. The probabilities are that you've got extensive scarring as well. It's probably going to be something related to the posterior capsule. So the big mismatch between a loose flexion gap and a tight extension gap, it's it can be, you can overstretch it, trying to just, what I would do is that I'll try to do as much posterior release as possible. So in fact, the first step is definitely starting with.
Majid, can you put your mic on mute, please?
Sure.
Go ahead. Go ahead, Fouad. No, Fouad got muted. Fouad, you're muted.
Yes. I just realized I got muted. I don't know why this must be a bug. Somebody muted me. Anyway, so I was saying that the main thing I would concentrate on first is to try to do as much posterior capsular release as possible, trying to enlarge the extension gap, which is tight, in order to sort of equalize the flexion and extension gap. Then obviously, if I do want to do any kind of resection, I would try to do a minimal resection as much as possible. I wouldn't like to go beyond 4 millimeter of resection. And then after doing that, you might sometime try to compensate for that by increasing slightly your tibial resection as well. Take a little bit from the tibia, which is counterintuitive because that will increase the flexion gap. But then I can try to compensate for that by using a bigger, oversizing the femoral component and trying to shift the posterior, the femoral component posterior by an offset stem. If having done all these maneuvers, I still cannot balance the knee, then unfortunately, you'll need to resort to something more constrained. The other thing that I always like to point at is that there is invariably some element of posterior translation of the collateral complex with a revision case scenario. So another thing in a sort of a mid-release step is to try to separate between the medial collateral and the posterior medial corner, trying to translate the medial collateral anteriorly. And this has been found to sort of increase 2 to 3 millimeter in the tight extension gap.
Vaibhav, any tips?
I think Fahad has covered almost everything. So use an offset stem to posteriorize, use augments, close the flexion gap as much as possible by balancing in the flexion itself. But if need be, your primary question is that if you've done all of that and you still feel that the extension is tight, I'm not a great fan of elevating joint line irrespective of the pre-existing patellar status. At the most, I'll take a 2 to 4 millimeter cut. I'll not want to go more than 4 millimeters. So try to balance it as much in flexion and only then see the extension side. Because the culprit is loose flexion and not tight extension usually.
See, the problem is that on flexion, on the flexion side, you can put maximum of 10 millimeter of augment, and you can posteriorize the revision femoral component, which by design is actually posterior. The housing is more anteriorized. But the problem I find is if you go maybe more than one size up, then you get a medial lateral overhang. Because usually in the revision systems, you don't have the narrow options like you have in primary. And with the Asian patients, particularly female patients, they have more of a narrow medial lateral dimension. They have more patella baja, as we have seen in our patient population. So I get more concerned when I'm dealing with a flexion contracture because you got to fix it in a primary situation where you prefer not to do too much of optional cut. I mean, as you said, probably in the index primary procedure, you do 2 millimeter more if at the end of your, before you finally cement all your component at the time of trial, you still had, 10, 15 degrees of flexion contracture. But then given the situation, we know that the Asian patients are more lax. Would you, if you've done everything in a primary situation, you're happy with your flexion and you have only 3 to 5 degrees of flexion contracture, would you be happy to close the knee with that, with a 3 to 5 degrees of flexion contracture, hoping that they will stretch out? And again, the patient is not a Caucasian, is an Asian patient.
Yeah. So female patients, smaller knees, I would do that. But larger Caucasian built, large meaning 4 or 5 or larger knees, I don't like to keep a flexion contracture. But females usually stretch out. Smaller knees stretch out, but larger knees they don't. So and also would depend what was his pre-op range. So if there was an existing contracture, I would not want to do it. But if it was not, I would accept in a female small knee a 5 to 7 degree contraction.
And you find that they usually stretch out
Yes.
over the next. Okay.
Yes, I do. Yeah.
Well,
Any further comments from Dr. Mohanty or Dr. Noor? Yeah, go ahead, Fouad.
Yes, what I was saying is that as a general rule, although I agree with Dr. Bagaria about what he said, as a general rule, I like as much as possible not to leave any residual flexion, contraction, or flexion position at the end. But then the one thing I might accept is if it is not a totally persistent flexion. What I mean is that sometimes you get these knees that when you leave them, they have a little bit of a flexion, and then when you press on them intraoperatively, they sort of get more extended
Spongy.
and you reach the full extension.
Yeah. So they're spongy. They don't have a bony block.
Exactly. So most of these cases, I mean, I tend to extend my release to the gastrocnemius attachments, and that sort of remove them more because usually the recoil is due to the gastrocnemius muscle. But then even if you leave them, then what Dr. Bagaria said, it might work. With your physio, then it might actually, you can get the full extension that you need. But if it's really such a tough flexion residual, I would be sort of wary of leaving them.
Any comments from Dr. Mohanty or Dr. Shahid Noor?
I think very nicely covered. I'm sure the audience might have enjoyed. So we need to understand the philosophy and the implant. Different companies have different things. For example, VVC in Zimmer would not allow a rotating implant. And with another company, you would have the advantage of VVC as well as rotating end. That might have an advantage on the fixation survival.
So that brings another question of rotation allowance. So with the PS and the CCK, how much rotation is there if you use a PS implant or rotation freedom versus a CCK implant? I've heard different figures. People say it's 8 degrees in PS, 1 degree in CCK, and a mid-level constraint, it could be 2 to 3 degrees of rotation. Any ideas or any suggestion?
I think the rotating implant in the primary, starting from LCS, we had said that it will have a long-term survival. But the registry data
I'm talking about fixed. I'm not talking about rotating implants. I'm talking about fixed bearing implant. Do we have any rotation freedom if you're using PS or CR as a primary versus how much rotation freedom you get in a CCK versus, I mean, of course, RHK has a rotation built in, obviously. So that was my question.
Yeah, Mohanty, you're muted, so please unmute and.
Yeah, am I audible? Yeah.
Yes.
Yeah, in case of normal PS implant, it depends on the port.
Iatrogenic flexion extension imbalance that we created by taking the PS out.
One of my colleagues in UK used to take 2 millimeter extra in all PS knee that he will balance his extension and flexion gap. I don't do that.
So he would take 2 millimeter extra, like in the distal cut of the femur.
Yes.
But okay, so that will be a very good option if you are in the Western Hemisphere. I think in our part of the world with the small femurs and patella baja, I don't think that's an option. I don't do that. Exactly. I mean, I would really do every type of posterior release, as Fouad mentioned, capsule, gastro. Even I sometimes go and look for any tibial osteophyte or a capsule release from the tibia slightly before I even think. And my red line will be actually 2 millimeter on the distal femoral cut. And again, that will be more in a big male who actually had a pre-existing flexion contracture, 20, 25 degrees, 15 degrees. 5 degrees, 7 degrees, 10 degrees, I really rely more on posterior release and try to accommodate as much as I can. But the thing that I've seen that you get these patients, you examine them postoperatively, 6 months, a year down the line in your clinic, and you find that they have slightly more increased AP translation while they have their knees in 90 degrees flexion. They're not symptomatic. They're perfectly happy. But on, you know that they have a looser flexion. They might be happier because, in the Asian patients, they're happy to bend the knee. They can do the squatting, the salah, the namaz, the prayers, whatever. But I think iatrogenically, we're creating something that I don't know what's the right or wrong answer. I mean, except that, if the fact that you have cut the PCL, you accommodate it by doing more release or doing more distal resection, as you said, Shahid. And then maybe, adjust your patellar height so that it's not too low, and recreating a patella baja.
Yeah, so
if I may add something, Mojieb.
Yeah, go ahead, Fouad.
Well, I agree with everything that you said. The one thing I found is of help in most of my knees is that the step-by-step technique. And this means that I would leave, against all the recommendations of the books, the excessive release of the posterior osteophytes till the end. And I know that most people tell you that you always have to relieve all the osteophytes before you're doing all your releases, which I usually tend to try to do. But when you start with your extension gap first technique, then you've actually, the baseline you're working on, which is your extension gap. And then basically, when you test that with your flexion gap and you find that there is a little bit of exaggerated sort of mismatch, or there's a mismatch between the flexion and extension gap, then you can actually tailor most of your releases in relation to that flexion gap that you've created by resecting the PCL. And this is something I've been doing regularly, because as you know, in our neighborhoods, it is very unlikely that you get a knee that you can put a CR on. Most of our patients come extremely late. They come when they have had a real problem in mobilizing. So most of my patients now get a PS. So the issue is that that there's always a need for more extensive removal of the posterior osteophytes. The collateral releases can actually improve significantly also the mismatch that exists. So it actually sort of increases your extension gap. And in most of the cases, I haven't come across, as you say, any complaint about this very slight sort of instability in flexion that you follow up with your patient after 6 months.
Yeah, we just detected it physically on physical exam without patients complaining of anything, and that was kind of something, a curiosity in our mind, that is it something we are creating, or is it, Vaibhav, you were saying something. Go ahead.
Just another point to add that it's not the flexion gap. It's it might be the flexion gap, but in addition to that, one should aim at restoring the posterior condylar offset of the femoral component. That is another important point that leads to flexion instability. So needs to be restored.
Vaibhav, go ahead, Vaibhav.
So you rightly said, I started with being a PS surgeon, then moved to CR surgeon, and now I'm both CR and PS surgeon because robotics determine what I should be doing. But what I've done is that when we do CR, my tibial slope is slightly more, the posterior tibial slope, compared to the PS. So that compensates for the 2 millimeter difference that you do from PS to CR. And also, as you rightly said, happiness for our TKR patient is a loose lateral space infection. So I think our happiest patient are those who have some degree of looseness inflection on lateral side. So I think we have all kind of tweaked our ways to get that happiness to our patient.
Sure.
Yeah.
Okay, I think it's 2:15 our time here, 1:15 at the Brussels time. Sufyan, thank you very much. And yeah, this is for the audience. This is a QR code. If you guys could kindly fill in the evaluation for this webinar. And we would like to welcome you for another series of webinar by the knee subspecialty committee. On the 31st of May, personalized knee alignment. On the 7th of June, painful knee joint. That's been done by the Sports Medicine or the Arthroscopy Committee. And then finally, we'd like to welcome you to our 44th annual SICOT meeting in Belgrade. That's in September 24 to 27, 25 to 27. Okay, so if there are no more questions, no more comments and concerns, I'd like to thank each and every one of our esteemed speakers. This has been a fantastic webinar. We all enjoyed it. We enjoyed the presentations, the discussions, and I'd like to thank you all.
Thank you.
Bye.
Thank you, Mojieb.
Thank you very much.
Thank you.
all.
Bye-bye.
Thank you all.
Thank you. Bye-bye.
Thank you all.